afternoon, everybody. Welcome to, welcome to everybody in the room, but also welcome to everybody who's joining us online. This is the first in our seminar series for the neurodevelopmental theme in the School of Psychological Sciences. And it is absolutely thrilling to see in the audience, everybody from our fourth year students to our doctoral students to our most senior research fellows and online, our graduates of the program, and senior colleagues in the clinical worlds, but also our philanthropists who support this research, and it wouldn't be possible without your generous funding. So it's very nice to see you here supporting us as well. Thank you very much. So I'm just going to say a few words about the neurodevelopmental theme. I'm reading from the notes on my phone. This is what our theme is about. Neurodevelopment is governed by genetically programmed processes that interact with environmental inputs across critical periods, particularly in the first 1,000 days of life. We know that disruption during these windows due to biological or psychological factors increases the probability that a child will be diagnosed with a developmental challenge or disability, such as autism or ADHD. These conditions disrupt the developmental trajectory of cognitive, communication, motor, and social and emotional skills. Globally, 1 in 6 children will be diagnosed with a developmental challenge or disability. We know that children with disability often face structural and social exclusion with lifelong consequences for health, education, and well-being. Our work in this theme bridges neuroscience, developmental science, and implementation research to co-design and deliver scalable, evidence-based models of care to improve developmental outcomes. Today, we're going to hear about 2 research projects that are expanding this field. And it's my absolute pleasure to be introducing Dr. David Mosley, who's a clinical psychologist and associate professor at Monash University. David has vast experience, over 2 decades of experience working with children with neurodevelopmental conditions, and previously was the psychology discipline lead in the early in life mental health services at Monash Health, and now advances our integrated clinical research models within the All Play and Turner clinics. David's session is going to focus on the need for transdiagnostic therapeutic approaches that strengthen parent and teacher, parent and child, but yes, parent, child, and teacher relationships, and promotes emotional regulation in primary school age children. It's also my great pleasure to be introducing Dr. Chloe Emerson, who's a research fellow in our school. Chloe's PhD focused on promoting physical activity participation for children with disability. Her work is now focused around taking clinical interventions and positioning them in the community so that we can scale mental health and physical health opportunities for all children through the All Play Child Family program. Chloe's presentation is going to explore the importance of promoting emotional regulation strategies for children in naturalistic contexts. So please join me in welcoming our 2 speakers today, and thank you all for joining us.
Thanks, Nicole. And it's really great to be here to talk to you all about something I'm very passionate about, which is about supporting parents and children to support their mental health and their development and well-being. There we go. So I'd like to start by acknowledging that we're meeting on the unceded lands of the Kulin Nations, and to pay my respects to elders past and present. I'd also like to acknowledge those with a lived experience of disability, diversity, or mental health. I acknowledge that we can only build quality care through valuing, respecting, and drawing upon the lived experience and expert knowledge of young people, their parents and carers, and the clinicians, researchers, and educators that support them. I'd also like to acknowledge that our program, particularly the All Play program, is supported by a range of industry and government and philanthropic funders, which we're very much grateful for. It's great to have Veron here from the Grosman Family Foundation, and together with the Shoreline Philanthropy Trust, have been part of the support of the program I'm going to talk about today. also the Krongold family, and Adam Krongold, the Ferrero Corporate Social Responsibility, and the Mecca Empowered Collective. So, in 2021, the federal government in Australia released the National Children's Mental Health and Wellbeing Strategy. And from my point of view, as a clinician working in frontline mental health services and providing a lot of support to psychologists and new graduate psychologists and other mental health clinicians coming into the sector, I really like this strategy. I think they really got a lot of things right, and it spoke to me about the needs, particularly of under 12s and their families. What I had seen in my time working was that the service provision to under 12s had actually reduced with increasing demand for mental health services and the service delivery not expanding, not being able to expand to meet that. We were seeing less and less under 12 services, which means they weren't getting into the services and also they weren't being referred into service. So this is a very strong need to prioritise this population. This strategic document highlighted a number of key pieces of data that are really relevant, I think. So one is that 50% of adult mental health disorders emerge before the age of 14 years. So the pre and primary school age group is a really key time for us to be building the developmental and mental health resources for children and families. We all know in this theme in particular that children with neurodevelopmental disorders have higher rates of emotional and behavioural difficulties. We know that more than half of children in need of mental health support in Australia are not seeking help. And this strategy, with very reliable data, made that very clear. 70% of paediatrician consults are now focused around mental health. And 2/3 of parents do not feel confident about how to recognise or respond to mental health issues and don't know where to go for help. We also have some issues in our clinical practice spaces and in our research and academic spaces. So when we look at the child mental health space, there are actually relatively few evidence-based interventions that have been developed specifically for the age group of under 12. And those that have been developed, there is good work in this space. Most of those that have been developed are focused on individual approaches with children or with parent-focused intervention. Either we're working with parents individually or with parents in groups. And there is good evidence doing both of those. But when we think about the developmental period that children are in the primary years, really the opportunity to work with children and parents together is a very important one, and there's very little work in that space. There's also a lack of choice and involvement of families and children with a lived experience in not only the design, but also the delivery of interventions. And both the National Strategy and the Royal Commission in Victoria to Mental Health Services have really highlighted the need for mental health service delivery to be much more collaborative than it has been. And this is a particular issue when we look at evidence-based interventions in clinical practice as well, because a lot of evidence-based approaches out there have been developed with a real focus on session-by-session materials. So you do this in week 1, you do this in week 2. And, you know, that's really allowed us to understand the evidence base, and treatment fidelity has been a really strong focus in the research work. But what that means in practice is that when the session content is extremely fixed like that, there's not an opportunity for parents and children to actually collaborate in the care that's offered, because it's very much prescribed by the manual itself. And so that's a real challenge. Like, how do we establish evidence bases for collaborative and flexible and personalized care? And I think that it is a challenge that we can confront and overcome. But you know, I don't know exactly what the results of this study I'm talking about today will be. So we'll have to wait and see. Primary school aged girls have been not only underrepresented in research, but also in clinical practice. So when I was training here in the early 2000s, we were taught that in primary school, boys mostly present with disruptive behaviour difficulties, and in adolescence, girls are more likely to present with emotional difficulties. And it was presented to us as just the developmental reality. And I went out into clinical practice, and that's what I saw. Absolutely. We had lots more boys in primary school age and more adolescent girls presenting. And I had thought that that was just the way that it was. With the more recent sort of gender lens on research and also on health delivery, it's actually becoming increasingly clear that the needs, the mental health and support needs of primary school age girls are actually being overlooked because they're more likely to present with emotional and social or relational symptoms. In primary school, those don't hit on the radar for teachers and parents necessarily as much, and they also can't get through intake systems in health service delivery. They're not seen as severe enough to be needing intervention. What I've also seen in my own practice working with adolescents and youth is that when you understand people's histories, it's quite clear that the difficulties that they're having have not just started in adolescence, that there have been regulatory and developmental and emotional challenges right throughout their developmental period of growth. And so there's a real opportunity, I think, and I would even say a responsibility for us to be designing and delivering interventions that are really appropriate across genders and not in a gender-focused way. As you'd be aware, a lot of the evidence-based interventions that are out there are also quite behavioural and again designed to meet the needs of those more disruptive behaviour sort of presentation in primary school age. So that's a big focus. There's also not really been a focus on how we can democratize psychology. How can we share? Like, I think as psychologists, we've got a lot of good knowledge, a lot of good research and practice, but we tend to hold on to it fairly tightly, and I don't think the culture has been to necessarily share that information and encourage other non-psychologists, to be doing psychological work. Now, obviously, you have to be a psychologist to be a psychologist. But the developmental and mental health support that children need takes a whole community, right? And so interventions, I think, would be enhanced if they could involve those non-clinical workers, whether they be family support workers or peer workers or NDIS support workers, or even whether they be grandparents and extended family and community members, particularly for our families who are experiencing more significant, complex, intersecting challenges. Those parents also really need support from others in the community around how to implement and support the practicing that is needed to build the mental health and development of children. So that's, I think, an important feature in what we're trying to do as well. Lack of connection between what's happening in the clinic, what's happening at school, and what's happening. And this is why I've come to join the All Play program with Nicole and all of the colleagues, because of the amazing work in bringing developmental knowledge and practice out into the community and helping kids to participate in their community, not only to enhance their well-being, but also with demonstrated benefits for their social and other areas of development. And I think we have a strong position as clinicians to really be endorsing and advocating and also supporting children and families to be able to access community-based programs so that they can also get benefit, developmental benefits and well-being benefits of participation in different aspects of the community. The last thing is that it has been quite difficult in clinical practice to integrate evidence-based models. And it's well described in the literature, but it's also very evident in practice. Most clinics that are out there, whether they're hospital clinics or private clinics, are not offering evidence-based manualized treatments, partly for the reason I spoke about before, because of the structure that doesn't really fit, also because they tend to be targeted at a particular diagnostic group. And in real life, children and families present with all sorts of transdiagnostic needs, so a single point of intervention is not going to hit it. But also, there's lots of good stuff that's been developed that just hasn't been able to scale, got out. So that's another focus for us. Fortunately for us, the national strategy was really clear about where we needed to head, and it very much aligns with my own views, which is we need to be more child-centred, more strengths-based, more prevention-focused. We need to focus on equity and access. We need to really be looking at developmentally appropriate interventions across the system, have evidence-informed and best practice with continuing evaluation, early intervention, and needs-based, not diagnostically driven. And you can see there along the side, there's a whole suite of All Play programs, some of you will be aware of, and they really do hit the goal of the strategy to be looking at supports across family, community, education, and the service system. So this is really the future of child mental health from my point of view. So I just want to get into talking a little bit about what the intervention is. So brief, serial, targeted clinical intervention for primary school age parents and their children together in the room together. That's what this is about. Transdiagnostic. So we are deliberately opening this to children coming with all sorts of different kinds of presentations and needs, including different diagnoses, multiple diagnoses, or no diagnosis at all, but where there are significant emotional concerns. Focus on the child. So the intervention materials are directed at the child who's in the room. They're also directed at the parent who's in the room and at the parent-child relationship. There's information in the intervention about how to adapt the different activities. If you're working with infants and toddlers, if you're working with early primary school or older primary school age children, how might you adapt these activities? And they're flexible and personalized to the needs and strengths of each family. So literally at the start, we come and find out about the child and family in a strengths-based way. And then the clinician and the family also understand the challenges and needs, and then they choose intervention materials. It's a developmental kit so that actually they're choosing the activities that they want to work on together collaboratively, which does present a bit of a challenge for research because the session number is flexible from 3 to 6, depending on needs. And also the activities that the families do will be different family by family because they will have different needs and they'll select different combinations of activities. So it's going to be interesting to see whether we can establish an evidence base for that. It includes the involvement of those non-clinical workers, and it does integrate with the other aspects that I talked about. So this is not a talk about how to deliver the intervention. I'm very interested to talk to anyone who wants to talk about that, and it's been great to work with some of our clinical and clinical neuro PhD candidates around training on this. But just to give you guys an idea, the activities themselves are designed to build the emotional awareness and communication of children and parents individually and together, to build emotional intelligence and emotional problem solving, as well as coping and calming skills. We've been developing some additional activities more recently that are focused around helping children with their sleep in partnership with our Sleeping Sound program. There's also specific activities around anxiety, sadness, grief, and also working in that really important but complex space about the relationship between alertness and emotional regulation that then can come into play around a whole lot of different emotional issues, but also hyperactivity, concentration issues that children might be struggling with. Chloe's going to talk a bit more about that element in her talk. So each of the activities most of them have a visual presentation component, but they also have on the back things for kids to try, and then things that parents and other support people can do to help. And these things are workshopped, personalized, and talked about within the sessions. But you can see there how there can be developmental adaptation for children of different ages, but also the involvement of those other support people in being possible through the intervention. And we seek to really try and find ways to help children to have their executive function scaffolded while they're still developing. So I won't have time to talk about some of the pictures of the brain that are in the talk, but you guys know that our executive functions continue to develop up until the time that we're 25 years of age. And in the primary school age years, we're still in the concrete operational stage. So those more complex, abstract thoughts, being able to think about thinking and being able to sort of maintain and monitor things over time, it's not really developmentally appropriate for primary school age. So we need to have parents involved, but also we want to provide them ways to think about complex things, but in more simple ways that are appropriate for their developmental level. All right. So attachment theory has a big focus here because we learn emotional regulation through our relationships, and bringing the parent-child relationship into the therapy room in primary school is a strong focus. And it has a very strong developmental basis because we are looking to try and figure out where children are in their development and where they need to, where the next step is, and what kinds of barriers and strengths do they have to be able to get to that really where we want to be going. There's also a number of other frameworks and theories that inform this work. The idea of serial brief intervention is really appropriate to the developmental period because you can't teach calculus to preppies. So it's not about one intervention and they're fixed for the rest of their development with whatever they need, right? It's actually about, oh, development's become stuck. Let's see if we can understand what that is. Development then proceeds, and then there might be a time when things become stuck again and they might need a little bit more support there too. So because we're developing, we need to be aware that children need a brief intervention, and then they can come back and have more intervention. They don't need constant intervention, and they don't just need a one-off. There's a range of other things that inform this work as well. There is some evidence, very little, and this is an area I'm interested to get some research support around, about from my looking, there's actually very little published literature that looks at having parents and children in the room together. And what is out there suggests, in line with the developmental neurobiology, it suggests that actually having parents involved enhances the treatment, and particularly also the gains and the duration that the improvements last for, which is really promising, but we will see. So I've been really fortunate to come as part of the All Play program with some work that we first started developing in the Monash Prongog Clinic, to come across here this year and to work with Catherine and the team here in the Child, Youth and Family Clinic. They've adopted the developmental kit and the My Emotions module as the model of care for primary school age children in the Turner Clinic. And we're working together. We're just commencing now a hybrid implementation and effectiveness study, a pragmatic randomized controlled trial with a waitlist control, and it's a 3-month waitlist control, 3 to 6 session intervention. And families come in, and if they consent, then they're randomized to one or other group. Interestingly, families wait about a similar amount of time because there is a little bit of a wait for service. So there's no disadvantage for people who are in that waitlist group. It just means they do an extra set of questionnaires earlier instead of later. We've got a range of measures, which I tried to keep the measures manageable for families. And so some of the measures are sort of just barely adequate, like the SDQ, but I was really committed to keeping the SDQ in this protocol because, as you'd be aware, right across Australia, mental health services use the SDQ. So we can really keep that evaluation going in practice in real service settings. And then there's a range of other domains that we're interested to look at, both on the effectiveness side in that pragmatic sense, as well as on the implementation and getting feedback from clinicians and from families about their experience with the service and the various elements of the program. So I just want to finish off by acknowledging the team under the leadership and support of Professor Nicole Reinhardt, who's really made all of this work possible. I'm very, very grateful for that. Also to Catherine Lawrence and Erin McKay here in the Turner Clinic team, and it's really lovely to be here and working with a really energetic and collaborative team who I feel like have really embraced this work, and it's a privilege to be here with them. Alex Yu is also on the team, and she works at Monash Health. So she's providing some research support at the moment, but also the longer term goal is to be testing some of these programs in some frontline services so we can get the next level of evidence. And we have a raft of students involved who are supporting the program, which is really lovely, and the All Play and Turner Clinic teams as well. So I'm going to finish there. My call to collaborators is very keen to hear from anyone, research, clinical, policy, any interest in this work. I'm really, really keen to partner and try and build something great here. But I'll pass over to Chloe now, who's going to talk about the school-based programs. Okay. Mm-hmm.
Wait for the questions right at the end. Yeah. Thanks.
All right. Thanks, David. So yes, now I'm going to move into talking about child mental health support in the community. And there'll be a bit of a focus on movement or physical activity for this part of the talk. So David spoke about the current kind of picture of mental health among Australian children and children with neurodevelopmental conditions, and the importance of clinical support. So I thought I would jump straight into providing some context around why it's also important to consider providing mental health support in the community. And a major reason for this, behind this, is the treatment gap, which is a well-documented concept and one that I'm sure most of you are pretty familiar with. And I'm going to draw on the work of Professor Alan Kasdan here to describe the treatment gap a little bit further. So the treatment gap has been recognised across various conditions, ages, time, etc. And it considers two key components, really. The first is the high prevalence of a condition, and the second is the delivery of services to support people who experience that condition. And in this case, we'll talk about mental health difficulties. And more specifically, the treatment gap refers to the difference in the proportion of people who experience a mental health difficulty and the proportion of people who receive care for that. It's also a fairly global issue that the majority of people with a mental health condition don't receive any support. There's a lot of different research to support this, but for an example, for treatment of people experiencing depression across 21 countries, research has shown that in high-income countries, about 1 in 5 people will receive treatment, and in low to middle-income countries, it's about 1 in 27 people will receive treatment. So the barriers to receiving mental health care are also well described in the literature and many, as I'm sure most of you will know, and are generally conceptualized either as a systemic factor or an attitudinal factor. And common barriers can include costs, having too few mental health professionals to service everyone experiencing mental health conditions, and this is especially an issue for ensuring that treatment is culturally appropriate. There can also be stigma, so that might impact or stop people from seeking out support. A person's level of mental health literacy, so what they know about the condition that they're experiencing and what treatment is available for them. And features of the dominant model of providing psychological support, which is typically characterized by kind of those one-on-one sessions, generally in person, although telehealth has obviously been around for a while and taken off with COVID and recent things like that, but still many sessions in person, and which are generally in clinical settings. So we can see how many of these factors can pretty easily start to interact and limit the amount of people who would be able to access treatment. So these barriers and features of the dominant model of care led to Professor Kasdan suggesting the need for multiple models of providing treatment to enhance the scalability and reach of supports. And some of those I've included on the slide here from one of Kasdan's publications. And I want to focus on 3 of the approaches here, and that's task shifting, interventions in everyday settings, and lifestyle changes, and how these factors relate to promoting children's mental health in the community. So firstly, task shifting focuses on expanding the workforce by involving lay people or people that are not typically involved in providing psychological support. For example, maybe teachers in the delivery of mental health support. Interventions in everyday settings is similar. So that encourages the delivery of supports in context beyond clinical settings, such as schools, which of course expands the reach and accessibility of treatments. And schools are the area of community implementation that I'll be focusing on today. So I'll speak more about that shortly. And the last approach that I wanted to highlight here is the use of lifestyle changes. So that suggests that health promoting lifestyle behaviours can be encouraged to support mental health. And I'll speak more about this shortly with a focus on physical activity or exercise. So I think we can all agree that children who engage in physical activity are more likely to experience better health outcomes. That's a pretty common knowledge these days. So the many health and developmental benefits of engaging in physical activity are widely accepted, and that's including for mental health, not just physical health. So just here, I'll briefly talk about some of the holistic benefits of physical activity. So physical activity is recognised as a factor that acts as a buffer against mental ill health. And to touch on some of the emotional and social benefits of physical activity in particular. So evidence has shown that physical activity can benefit or reduce and prevent symptoms of internalizing disorders like anxiety and depression, and also externalizing behaviors. Physical activity has been linked to increased self-esteem and can help with emotion regulation. It can also foster a sense of belonging and inclusion, and can increase opportunities for social interactions. And this is also true for children with neurodevelopmental conditions, where physical activity has been linked to better mental health and psychosocial well-being. And in fact, more than a decade ago, researchers described the amplified importance of physical activity for children with disability for many reasons, but because they are at greater risk of experiencing health difficulties in the first place and secondary conditions. Yet many children, especially those with disability, often don't meet the recommended amount of daily physical activity. So we can see from the guidelines, the Australian guidelines here, that sits at around 60 minutes or more a day of moderate to vigorous physical activity, and also several hours of light physical activity as well. And this slide here just shows the first global physical activity guideline specific to people with disability, which aligns with the general recommendation in the Australian guidelines, so still sitting around that average of 60 minutes of physical activity per day. But I wanted to point out here that it's recognised that doing some physical activity is better than none. So this leads into the next section of my talk, which will certainly not talk about highly vigorous or competitive exercise and sports, but more enjoyable movement. So I'll spend the rest of my talk providing an example of how we're putting the concepts that I've started to talk about so far into practice to support children's mental health. And to do this, I'll be talking about a program that we've developed called the Joy of Moving program in Australia, which joins a global Joy of Moving program designed to encourage playful physical activity among children to foster their positive attitudes towards movement. So Joy of Moving is an international social responsibility project by Ferrero, and it aims to encourage, as I said, enjoyable movement among children. The Global Joy of Moving initiative also recognises the value of using physical activity to support children's holistic development, and in particular for their motor skills, cognitive functioning, creativity, and life skills as well. And it's all through enjoyable and non-competitive activities, with that belief that fostering a positive attitude towards movement and physical activity during childhood will help children develop into thriving adults. So since it began nearly 2 decades ago, the Global Joy of Moving initiative has involved more than 60 million children across 34 countries. And again, it's just really about promoting collaboration and fun rather than performance and competition. And the program's been delivered through unique iterations in each country it's been implemented in so far. And we received a philanthropic donation from Ferrero to develop the Australian iteration. Given our background in psychology, the local iteration that we designed here in Australia has a mental health emphasis. So it integrates psychoeducation with physical activities and is delivered in primary school classrooms. So it was developed by psychologists, educators, disability experts, physical activity experts, and as I said, is delivered in primary schools by classroom teachers. So it has a really flexible design, but in practice, it would involve a teacher pairing psychoeducation either through a movement, storybook or an animation video with a movement break in the classroom, and that whole thing would be about 10 minutes. The psychoeducation materials each focus on a different emotion and also the science behind using physical activity to regulate emotions. So we've taken quite complex constructs and science and tried to really translate that into accessible and practical resources for children that can be used in classrooms with brief movement breaks to encourage the understanding of that connection between emotion regulation and physical activity. And this brings me to, or brings together some of the concepts that I've spoken about so far, like task shifting. So of course we have classroom teachers involved in the delivery of this type of support. everyday environments where the program is implemented in classrooms to hopefully reach thousands of students, and lifestyle changes where we're using physical activity to build mental and physical health by teaching children skills to regulate their emotions using movement. So here's a couple of examples of our psychoeducation materials, because these ones are a little bit harder to explain or conceptualize, I guess. So up the top is an example of a storybook, and we have 9 of these. Each book follows a similar storyline, but focuses on a different emotion. So we can see here, this one is about feeling angry. So the book starts with what it might feel like for a child, kind of brain and body experience. And then by the second half of the book, it moves into using or suggesting physical activity as emotion regulation strategy, and a little bit of that science as well. And there's obviously more pages than 3, but just to provide that example. And these storybooks were developed for kind of the younger levels of primary school. Down the bottom is an example of an animation video, which includes a little more complex scientific information. These were designed for the upper levels of primary school. And there's also 9 of these, and I'll try and play this example in a minute. So we tried to pair many of the storybooks and animation videos together to cover a range of the different emotions that we were touching on in the program. So you can see here, both of these resources cover feeling angry. I might see if it plays now.
When I feel angry. Riley gets angry because another student did not follow the rules of a game which helped that student to win. Riley thinks it isn't fair. He feels frustrated and annoyed. Riley gets fired up and feels hot. He starts sweating. His body tenses and he feels like he's going to explode. Riley gets so angry that he wants to yell and slam the door. He starts to think, I've had enough. I'm sick of this. I just want to get out of here. But did you know moving can help us feel better when we are angry? When we move, we use up our adrenaline, which is an energy hormone in our body. This can help us feel relaxed and calm. A movement break could help us when we're feeling angry. We could go for a run or shoot hoops with a friend. Remember, any movement is good movement, but if moving doesn't help you feel better, you can always talk to your family, friends, or teacher about how you are feeling.
So the idea is that teachers would either read the storybook or play the animation video, and then engage their class in a quick movement break using a movement activity of their choice. So really kind of pairing those 2 activities together. Okay, so getting into some of the research now, we have conducted feasibility and acceptability pilot trials of the program in mainstream and specialist school settings. So during the development of the program, a specialist school PE teacher was invited to review the resources and assess the appropriateness of the psychoeducation and movement activities for that context. And then, of course, we adapted based on that feedback. So some of the differences between the program for specialist and mainstream schools included using the storybooks only as psychoeducation in specialist schools, so not the animation videos, and also some changes to the movement activities that we provided. So we added some and removed some others. And we ran a pilot trial of the program across 24 schools, so mainstream and specialists. And we had 244 teachers involved in the delivery of the program, which meant it reached over 3,000 students. Alongside that trial, we conducted some other studies, and mainly reviews, which provide some more context around the Joy of Moving program in Australia. So a systematic review of physical activity breaks in mainstream classrooms showed that classroom-based physical activity breaks can support children's enjoyment of physical activity, some self-beliefs such as self-confidence, and their quality of life. And we realised that less research has been done regarding the use of classroom physical activity breaks in specialist schools for children with disability. So we conducted a systematic mapping review and found that only 7 active break programs had been reported in the literature across all time and locations that we could identify. So we identified this as a really important and unique direction to take the program. And the trial in specialist schools actually formed part of my PhD research. So I tried to use that opportunity to understand in depth from specialist school teachers more about the use of movement breaks in this setting, and that's what I'll focus on today. So given the novelty of this type of program, understanding feasibility and acceptability was the primary aim of this research. And it was conducted within a pilot randomized controlled trial. So I'll focus on the feasibility and acceptability today and how that aligns with using these novel models of delivering mental health support to children. And in doing that, of course, I report on data from the schools who were implementing the program. So in the first phase of the program, when we were conducting the trial, program delivery was obviously a bit more prescriptive than the flexibility that I've described so far. So we asked teachers to deliver the program through 10-minute classroom movement breaks 4 times per week for 8 weeks of a school term. And the 10 minutes included both activities I've been talking about, so the psychoeducation and the movement. Teachers were asked to use one of our psychoeducation resources per week, so stick to that one and move on in the next week with movement activities of their choice. We had about 40 primary or junior school classrooms and their teachers across 5 specialist schools implement the program. Students were primary school age, of course, so about 5 to 12 years, and most schools involved in this research primarily catered to children with intellectual disability, although students also experienced other neurodevelopmental conditions. So the most commonly reported conditions in this research was intellectual disability and autism almost equally, and followed by ADHD. 22 specialist school teachers reported on the feasibility and acceptability of the program. 7 did this through semi-structured telephone interviews. 18 teachers completed open-ended survey responses, and 19 teachers completed quantitative survey items. The qualitative data were analysed using a predominantly deductive thematic analysis, and that coding was guided by feasibility acceptability frameworks in literature, and quantitative data were analysed using descriptive statistics. So given the lack of research that had been conducted on the use of classroom movement breaks in specialist schools, it was really positive to find evidence for the program being feasible and acceptable. Especially because this provides some support for the use of these kind of novel programs that could provide mental health support to children. So many teachers reported that they would recommend the program to a colleague, that it fit well within their daily routine, and several voiced students' enjoyment of the activities as well. Intent to continue using the program was captured qualitatively and quantitatively. As is quite typical in school context, teachers also did describe time constraints. So this had factored into our decision to design the program to be delivered through those brief active breaks. But we all know how packed school timetables are, so that was still coming through as a bit of a barrier. Other common divergences in terms of feasibility and acceptability related to the age of the students and developmental needs of each kind of level of students in the class. So for example, appropriateness was demonstrated in several classes, but not all. And this appeared to mostly relate to the age of students. So it was least appropriate for the youngest and the oldest primary school classes. So really that middle age was best fitting. And also developmental levels. So it was less appropriate for the students with the highest support needs. So teachers therefore discussed the importance of having flexibility to tailor the program, whether this be according to age group or the needs of the class. For example, some teachers told us that it would be helpful to have extra resources to support the delivery of the movement activities so that all the students could engage in the movement in a way that aligned with their strengths and abilities. On to findings, some of the findings about changes that teachers described. So these findings that I'm reporting are reported in my thesis, but not yet a journal article. So I just wanted to note here that I'm sharing some unpublished data that I look forward to hopefully publishing soon. And it was really interesting to hear changes that teachers described for themselves in the program. So teachers said that the program brought more awareness around the language that they used for delivering physical activity breaks in their classroom to help children understand the reason for why they would be doing that and the benefits of physical activity, which does kind of relate to their role as a task shifter as well. It was interesting because our systematic review obviously didn't capture a lot of research around physical activity breaks being used in specialist school classrooms. But before the delivery of the program, we did understand that it was quite standard practice. So they're obviously doing it in practice, but not a lot of research around it. So it's nice to know that teachers kind of went from just being like, let's just do a movement break to let's do a movement break because it can help us feel good and help us learn. So really providing that kind of education to the students around why. With regards to students, teachers told us that the program helped students to recognize active strategies for feeling calm in the classroom. For example, a teacher told us that a student in their class started to ask to use the program resources when they felt frustrated or anxious. You know, they asked for an independent break, I guess, when they felt they needed it. So the student would ask them to read a storybook to them and then choose a movement activity to do. So that was really great. Teachers also reported that their students developed some emotional literacy skills, including emotional awareness, so being able to recognize emotions in the classroom, and also vocabulary, so especially around labeling different emotions and also talking about things like endorphins, which came from our psychoeducation materials like the storybooks. Of course, variability in specialist school context did come through again, so it was emphasized. So some teachers had some concern around whether or how much of the concepts were being understood by the students, and others didn't describe too much change that they observed among their students. And I think that could be to do with the fact that they were already using active breaks quite commonly, obviously not psychoeducation, but movement breaks were quite common. From an engagement perspective, teachers also reported that the movement breaks helped students to re-energize and improve their concentration. And I'll just also say briefly about mainstream schools, because I have been talking a lot about the specialist schools. We heard mainly from teachers in the specialist school research, whereas in mainstream schools, we asked students to complete a self-report measure of emotional and behavioural functioning before and after they did the program. And these findings are currently being submitted to a journal for publication at the moment. So I won't go into too much detail other than saying we had some really promising findings indicating significant reductions in emotional and behavioural difficulties that the children were experiencing for those that engaged in the program. So we look forward to publishing that soon. And just to loop back to, I guess, the broader purpose of the talk as well, it really highlights the value of promoting emotion regulation strategies for children in naturalistic contexts, and the value of developmentally appropriate interventions outside traditional clinical environments. But I'll also pause here to say that this, of course, does not discount the importance of traditional clinical services, which are so very required. It just really advocates for the need to have supports both in the clinic and community. Just want to make that very clear. Okay, so after we've done the feasibility and acceptability trials, we formed a living lab so that stakeholders could help us design the next phase of the Joy of Moving program in Australia. And this involved bringing together representatives from industry, government, health, academia, and of course, educators to share and discuss the existing findings and talk about ways that we could take the program forward to increase the program's uptake and understand how these practical and accessible resources could be used to foster children's mental health in schools in a scalable way. The result of this was the development of an online platform that puts our work directly in the hands of teachers and students. So all of the resources that I've been speaking about today, the storybooks, movement activities, and animation videos, which are now grouped under the term of our mood breaker resources, are freely available online to schools and also to families. So they're essentially the same resources, but we do frame them a little bit differently on the website, just so it's really clear that they can be used in home and school for families. We also developed an online professional learning course for educators, which is also freely available via the website. And the course provides educators with the knowledge and resources to implement movement breaks and psychoeducation resources in the classrooms to support children's emotion regulation. So it provides suggestions around implementation, but no longer in a prescriptive way. So it's really just about providing educators with the resources and helping them to find the most appropriate way to use those resources in their particular class. It also provides some background information about related concepts like the development of emotion regulation and also some adaptations to support teachers to tailor the strategies, because we obviously heard from the first phase of the research that was super important. Our next phase of research is also embedded in the course. So we are interested in getting feedback from the course about what educators are learning by completing the course, but also taking an implementation focus aligned with the aim of scaling the program. So we're really keen to understand how the course can help translate the program into practice, and we're leveraging frameworks like the REAIM framework to do that. So if anyone knows teachers that would be interested in completing a course like this, please feel free to share. The QR code goes to our website, which will link you through to the course, or contact us for the link. Definitely very happy to share it. And the course can be completed with or without engaging in the research. So we would love to hear from as many teachers as we can, but it is open, the research is opt-in. We're hoping this scalable program provided in a community-based setting can help to overcome some limitations associated with that predominant clinical one-on-one model of care. And I also included one of my favorite quotes from the specialist school research on this slide, which I think really encapsulates the value that these programs have. And I will finish up now just by saying, so my talk today did focus on the Joy of Moving program in Australia, but in the interest of talking about mental health promoting activities for children in the community, I also just wanted to take the opportunity to mention the All Play programs as well. So the All Play programs, as we've heard about today, aim to improve children's psychological and developmental outcomes by developing, delivering and scaling programs across clinic and community settings. One program in a community setting that has had success so far has been the All Play Foot program in partnership with the AFL. And some research that we did within that program found that participating in AusKick, so the community football program for young children, reduced anxiety among autistic children aged 5 to 12. So really highlighting a mental health benefit from this really an everyday community program. And we're now conducting a trial to understand the developmental benefits of dance for autistic children. So recruitment is currently open. If you know of any families that would be interested in involving their child with autism in a 9-week dance program, please scan the QR code or let us know. We will send you the link. I'm happy to send the link. That's all for my presentation. I think we might have a couple of minutes for questions.